Thank you very much to the NCRI for giving me this opportunity for a short 10-minute presentation. I'm very much looking forward to the Q&A afterwards, because it's obviously very difficult in a 10-minute presentation to do full justice to the topic. My disclosures are my post and my department are funded by Marie Curie, and I also receive funding for my research from the NIHR. My starting point is that prognostic information and prognostic awareness is important for patients, carers and healthcare professionals. And that's because we know that patients who are unaware of their prognosis are more likely to prefer aggressive care, whether or not that's in their best interests, more likely to receive aggressive care, have worse quality of life, less likely to complete advance directives, and are therefore less likely to receive care which is consistent with their preferences. And they're less likely to receive access to hospice services. So prognostic information and prognostic awareness are clearly important issues. But how is this information currently conveyed to patients and to families? There's been quite a bit of research in this area over the years, and in summary, the research suggests that not unexpectedly, patients and families want honesty from clinicians. They also want accuracy, although there is some uncertainty about the level of accuracy that people want. Do they want information presented in terms of bald statistics and numbers, or in a more qualitative fashion? Patients want hope, and yet they also want realism. They want their prognosis to be delivered by somebody with expertise, preferably a senior doctor, somebody who's deemed to be trustworthy, and preferably somebody with whom they have a prior relationship. I think you can see from just looking at these that it will not always be possible, particularly for patients with a poor prognosis, to easily reconcile honesty, accuracy, hopefulness and realism. So just how accurate do patients and carers and family want a prognosis to be? This is some research which we recently undertook as part of a prognostic validation study, and we interviewed patients and carers of people at a hospice. And I'm just going to read you a few illustrative quotes. One carer said, "I think if I had a rough idea, I think that would make things a little bit easier for me." A patient said, "I'd personally go for the actual weeks, days, years sort of number, rather than percentages." Another carer said, "Rather than being given statistical information about my husband's time left, I'd rather doctors said to me it's days or weeks, rather than there's a 50% chance he'll still be here in a couple of months." And these findings chime with other research, which also suggests that patients and families understand that it is not possible to be completely accurate in any prediction because it involves the future, and the future is uncertain. How accurate are clinicians' predictions? This was a study that we undertook a few years ago, where we asked doctors and nurses to put their heads together and come up with their best estimate about whether patients with advanced cancer were likely to live for days, weeks, or months. The patients were followed up to see how accurate these predictions were. If you look along the diagonal of this table, that represents the correct predictions. The clinician said days, the patient lived days. The clinician said weeks or months, and the patient lived weeks or months. You can see that overall these predictions were accurate on about 60% of occasions. By chance, three categories, you'd expect people to get it right about 33% of the time. So clinicians are better than chance, quite a lot better than chance, but it's still only moderate accuracy overall. Hidden within there, there's some interesting findings. So for instance, when clinicians are asked whether somebody is expected to live for days, and they say that they think they're going to live for days, that's pretty accurate. 90% of patients whom clinicians thought were going to die within days did actually die within days. But it is important to remember that actually in this study, well over 130 odd patients did die within days, but were not recognised as dying within days by clinicians. So is there any way we can improve clinical predictions of survival? Well, one thing I've alluded to already is that a doctor and a nurse and other members of the MDT putting their head together are probably more accurate than a doctor or a nurse alone. There's also some evidence that prognostic skills might be teachable to medical students or junior doctors. My colleague Nicola White investigated expert prognosticators, tried to understand the unconscious judgments that they were making, and then taught those strategies to medical students, and found in a pilot study that she was able to improve their prognostic skills. Although in this pilot study, that improvement was not maintained. So clearly more work needs to be done to improve ways to embed this knowledge in students. And finally, another way we can improve prognostication is using prognostic tools. There are lots of prognostic tools have been developed in palliative care. Perhaps one of the most widely used is the Palliative Prognostic Score, or the PAP score, developed over 20 years ago. The score is calculated by scoring symptoms. If the patient's breathless, they score a point. If they've lost their appetite, they score 1.5 points. Also looking at their Karnofsky performance status, the KPS. If they're very dependent, in bed, needing all care, they score more points. Similarly, points are scored for various blood parameters. But the most important part of the score is the CPS, or the clinical prediction of survival. And you can see that if a clinician thinks the patient's going to live for 11 to 12 weeks, they score 2 points. Whereas if they think they're only going to live for 1 or 2 weeks, they score as much as 8.5 points. You tot up the scores, and it divides patients into 3 risk groups. Those with the best survival prospects have a greater than 70% chance of surviving 30 days. And those with the worst, in the worst group, have a less than 30% chance of surviving 30 days. And this score has been well validated, and it does indeed divide patients into those categories. My problem with it really has been that the time I most want to use a prognostic score is precisely those occasions when I'm least sure about what the prognosis is. And therefore it's a bit frustrating when you go and look at the scale and you discover that actually it's throwing the question back to you. And by far the biggest part of the weighting is on the clinician prediction of survival. And the other reason I'm not entirely in favour of the score is that I'm not sure how clinically useful the output is. What would it mean to have a 30 to 70% chance of surviving 30 days? How would I use that information? Does that really tell me whether I am likely to survive 30 days or not? And how would you explain that output to a relative or a patient? These were the stimuli to producing our own prognostic tool, the PIPS model, which we've recently just validated in another study involving nearly 2,000 patients across England and Wales. And in that study, we found that it had an excellent ability to discriminate between patients with different prognoses. And when we divided patients into those risk groups I talked about earlier of days, weeks and months, we found that it was as good as the combined wisdom of a doctor and nurse. I say as good as, of course you could say no better than the combined wisdom of a doctor and nurse. It would have been nice, I think, if we could have shown it was better than, if you like, the gold standard clinical prediction. What we did show was it was at least as good as the gold standard. You can put the data in. It involves information about the patient's condition and some blood results, but crucially it does not require information about the clinician's estimate. So it is free of the subjective estimate of the clinician. It starts with a warning saying that, you know, this is no better than or as good as a multi-professional estimate. So don't throw out your clinical judgment just because this has been produced by an algorithm. To emphasize that, it asks the clinician to make their own prediction, to sense check the output, and then it makes its own prediction about whether the patient will live for days, weeks, or months. And it also gives a best case and a worst case scenario. What's the probability that the patient may only live as short as a few days, and what's the probability they might survive for a few months? So in summary, I think it's important that we realise that prognostic estimates will never be completely accurate, and that's not necessarily a bad thing. I personally, and I suspect many patients, don't actually want to know the exact hour or day on which they're going to die, but they do want to know their prognosis well enough or good enough to inform their decision making about their future care. We might be able to improve our accuracy by harnessing the power of the MDT, and we might be able to improve it further by using prognostic tools. Thank you very much.
Thank you, Paddy, and congratulations on a very succinct presentation. It's very interesting to have that focus on prognosis and accuracy. If I can take this opportunity just to remind delegates who are joining us, please do remember to send your questions in and also to like your questions in the Q&A bar on the right-hand side. At the minute, I just see a couple in there, so we'd be really delighted to have more in terms of feeding into the Q&A session, which will come at the end. So moving forward, I'm really delighted to introduce our second speaker, Professor Annmarie Nelson. Annmarie is a Marie Curie Professor of Supportive and Palliative Care and the Scientific Director of the Marie Curie Research Centre based at the School of Medicine in Cardiff University. Additionally, Annmarie is a member of the NCRI Living With and Beyond Cancer Executive Group and Chair of Living With and Beyond Cancer Advanced Cancer End of Life Workstream. She leads the Palliative Care Work Package at Wales Cancer Research Centre and is also the Palliative Care Work Package leads for the Primary Care and Emergency Centre Health and Care Research in Wales. Her research is focused on patient and carer experience, and this work is predominantly in the oncology setting, where she has a particular interest in patient experience of interventions, treatment decision making, trials methodologies, and the implementation and impact measurement of research outputs into clinical practice. Key interests are the decisions around stopping chemotherapy and aggressive cancer treatments when they are futile, and when toxicities outweigh potential benefits, and particularly looking at how these decisions are or are not made. In tandem, she is currently working to establish the acceptability of biomarker tests that will determine which patients will benefit from treatments. Annmarie's research portfolio includes phase 2 to 3 clinical trials in oncology and supportive care, national surveys, patient-reported outcome tool development, implementation research, and multi-centre, multi-country qualitative research. So, Annmarie, you're very welcome, and we're delighted to have you here today. Annmarie's presentation today will be narrated due to the effects of long COVID that she's currently experiencing. Annmarie is here with us and will join in the live Q&A and also at the end of the presentation. And Annmarie, we're really grateful for that participation today. So we're really delighted to have your narrated presentation, which will focus on talking about death and dying, why it matters.
Hello, I'm Professor Annmarie Nelson. I'm Scientific Director at the Marie Curie Palliative Care Research Centre at Cardiff University, and thank you for the opportunity to talk about public and professional attitudes and about treatment decisions in advanced cancer. It's said that we're a death-denying society. Death is a public health issue. It has 100% incidence, yet it's hidden from view and under-resourced. Will that change because of COVID? In this talk, I will discuss public attitudes to death and dying, based on a pre-COVID public survey from 2018. I'll also talk about a study called PACT, which is about treatment decisions in advanced lung cancer. And I'm going to focus on communication before looking at how the COVID-19 context may be a force for change. We had a large number of respondents for our tiny population in Wales, and they identified as bereaved or current carers, health and social care professionals, health researchers, just general members of the public, but we also had over 100 people who considered themselves to be in the last few years of life. This was pre-pandemic, and so it serves as a useful baseline for our new COVID world, and also hopefully gives pointers for some actions we might be able to take to improve awareness around death and dying. The survey used mixed methods with categorical replies, but also free text boxes so that respondents could give their personal perspectives in more detail. They told us that it's clear that death and dying is still taboo in social interaction. Respondents told us that they were careful of other people's feelings, that others may not be interested, and that it's often socially inappropriate, they said, to discuss such a sensitive topic. They talked about a lack of opportunity and resources. Healthcare professionals were thought to be too busy or didn't have the skills for such communication. Despite the excellent range of resources that are available for advanced disease and end of life, it does seem that these aren't reaching the general public, and maybe some more work needs to be done here to get them earlier on in the healthy population. We asked about end-of-life care planning and covered a range of actions: funeral planning, expressing wishes, organ donation. But if we're not talking openly, we're not prepared. And if anything, this pandemic serves to highlight how we should all be taking actions to communicate our end-of-life preferences, even if we're healthy now. The table may be too small to read, but just look at the range of responses in blue. Blue represents actions that have been completed, but red indicates intentions that haven't been followed through. So by looking at this, you can see there's a willing population here that are ready to tackle these actions with maybe a bit more of a push. We asked respondents to tell us about care and services they preferred towards end of life. It may surprise some to see that being at home or even being in a familiar place is quite far down the list, over halfway down. What is more important to the respondents, they told us, was the environment and the tenor of care. They talked about access to trained carers, calmness, privacy and dignity, and most of all having their loved ones around them. COVID prevents many of these aspirations, but in the future these are preferences of the public that could shape service provision. But further work needs to look at how the views of people like these, generally healthy respondents, may or may not change as illness progresses, especially in relation to preferred place of death, which is a driver or quality indicator for many services. We asked respondents, how can we improve communication around death and dying? They suggested using mainstream media, social media and other public platforms, embedding within education, and by promoting existing services and encouraging GPs and other health and social care professionals to take a lead. Some also suggested mandatory approaches to funeral planning and advanced care planning in care home settings. So that's maybe a step too far, but it's certainly maybe food for thought. I want to highlight one of the survey findings by introduction to the next study in this talk. We asked what was important to respondents in terms of quality of life, and here is what they said. Overwhelmingly opting for quality of life over survival. And although we could argue that these views might change when actually facing terminal illness, there are other factors in play, as I'll discuss. I became interested in the topic of costs versus benefits of treatment, and importantly, when is it time to stop treatments, when I first read a National Inquiry report about 10 years ago. In this, there had been a nationwide survey and case review of chemotherapy, and they found that 43% of patients who died within 30 days of chemotherapy suffered grade 3 or 4 treatment-related toxicity, so serious side effects. They considered that chemotherapy was prescribed inappropriately in 35% of cases, and 85% were admitted to hospital in the last 30 days of life. To this day, the 30-day mortality rate for advanced lung cancer is around 10%. So I wanted to look at how these often inappropriate treatment decisions were made. The PACT study is the result of this, and this paper that you can see was published in the last month. One key finding from PACT is, in this age of so-called personalised medicine, the notable absence of the subjective patient wishes and social context during the multidisciplinary team for treatment recommendation. But for this talk, I focus on communications and why open communications matter. So we know that talking about death and dying is often socially taboo, and that hope is important, and both of these issues intersect during decisions about treatment. These clinicians here each make assumptions about patients' knowledge of their prognosis and preferences for focusing on treatment. But whose role is it to make sure patients are informed? Should patients know what they're facing before they decide on treatment? Should patients end up in the oncology consultation and still not have an awareness of their prognosis? Here's an example of a consultation, and the patient is asking about the how long question and talking about it in terms of a holiday. And both the companion and patient are shocked when the oncologist answers very honestly that patients like you would probably not be alive in a year. These are really difficult interactions for the clinicians, who we saw frequently having to skillfully negotiate patients' prior expectations, physical deterioration, and unexpected personal situations in real time, while still guided by the treatment recommendation from the multidisciplinary team. But clearly the patient cannot make an informed decision without knowledge of prognosis, but also by weighing up the cost benefits of treatments, including a realistic account of the side effect burden. However, sometimes the clinician's accounts and the patient's experience are profoundly different. This clinician uses fairly benign descriptors of the side effects: mild skin reaction, little bit of inflammation, very small amount of side effects, and comparison with other patients where he says that most people will tolerate it, to describe radiotherapy treatment. However, the patient's account describes the reality in emotive terms. He actually says horrendous, I think, 4 times. Patient experience is a valuable subjective measure. We can't quantify it or generalize it, but it often challenges our assumptions. We have a lot to learn from patients, which is why I do the work I do in patient experience. In the PACT study, the key findings indicate the need for open conversations, both interprofessionally and with patients and families. Please take a look at the paper to see the full study, but for now, the many misunderstandings we saw and the benevolent efforts to preserve hope in patients can, unfortunately, contribute to inappropriate treatment and avoidable harm for some terminally ill patients. We need to reconsider the concept of hope in this context. There is no hope of a cure sometimes, and that is a fact that is best acknowledged and communicated. Instead, reframing and redefining the concept of hope in terms of living as well as possible for as long as possible will better support informed decisions and choosing appropriate treatments. Turning to current times, both of these studies were pre-COVID, and now there are further complications, one of which is reduced cancer treatments. It's becoming clear that some patients have missed opportunities for early diagnosis or even curative treatment. A recent paper in Lancet Oncology reports an estimated increase in deaths due to cancer up to 5 years after diagnosis, increasing between 4.8% for lung cancer to 16.6% for colorectal. These issues will add another layer of complication to future treatment consultations, and clinicians and patients will need extra support to negotiate some very difficult interactions. We're also dying differently. Sensitive conversations are taking place in emergency situations from behind masks, placing stress on inexperienced staff and impacting on the quality of care for patients. Families are enduring forced separations at the most difficult times of illness and bereavement. We've been working in the area of bereavement for several years at the Marie Curie Centre at Cardiff University. This work is led by my excellent colleagues, Dr. Emily Harrop with Dr. Morella Longo. We are predicting a tsunami of complex grief issues following COVID bereavement for the reasons already discussed and more. We want to understand the more from bereaved family and friends' real experiences to inform future services. We're collaborating with Dr. Lucy Selman from Bristol University and a team of experts from across the UK who have kindly collaborated to help us gain insights from a public survey. Please do look out for the tweets or flyers and let us know if you can help to recruit participants for this important step. Finally, the daily updates on mortality counts and rates deliver numbers, but don't talk about quality of death. But they are consistently highlighting the public health message and a deep awareness around death and dying. We now need to optimise the conversation and support a societal shift to pay attention to how we die and how we make sense of mortality. In the UK and across the world, the pandemic has highlighted the role of palliative care as a driver of best practice. This pandemic provides an immediate opportunity for a societal shift and to learn from end-of-life care and communication of patients' priorities and preferences, and to highlight death and dying fairly and squarely as a public health priority. Thank you.
Thank you very much. Sorry I wasn't able to deliver this talk live today. That was a very surreal experience for me, I must say. Just to say that I will be here to answer questions with the panel at the end, and that I have no disclosures other than the fact that I am funded by Marie Curie. Thank you.
Thank you again, Annmarie, for your really excellent presentation and the focus on communication and the role of hope and decision making. And also, I think I'm bringing us right up to speed in where we are at the moment in relation to COVID and bereavement in the context of COVID. Delegates, just to say, please do remember to send in your questions and also to like your questions in the Q&R bar on the right hand side of the screen. It's great to see so many coming in, so please do keep them coming. Last and by no means least within this session, I'm delighted to introduce our final speaker, Carolyn Canfield, who will be discussing managing your healthcare, the informed patient. Carolyn works as a global citizen patient to expand opportunities for patients, caregivers and communities, to partner with healthcare professionals in research, teaching, improvement and governance. My goodness, excuse me. Carolyn's full-time volunteering earned her recognition in 2014 as Canada's first patient safety champion and appointment as an adjunct professor in UBC's Department of Family Practice, where she currently collaborates with the Innovation Support Unit. In addition to teaching in the undergraduate medical programme and in the School of Nursing, she serves on the Faculty of Medicine's Admissions Committee to select candidates for Canada's largest medical school. She's also co-founded the National Patient Advisors Network to develop capacity and leadership among patients and carers, partnering with healthcare professionals across Canada. So again, Carolyn, you're very welcome, and please do start when you're ready.
Thank you very much, Joanne. It is such an honor and pleasure to join you today, to join Paddy and Annmarie. So I have no disclosures. As was mentioned in the introduction, most of the work that I do is as a volunteer, and when I am paid, it's by publicly funded organizations. So clearly, I don't represent all patients, and especially in the topics we're dealing with today, views are very individual, as Annmarie has shown in her research. But I do offer a patient perspective. Now, Paddy talked about the importance of relationship, and I think that what he was saying about the needs for accuracy and prognosis really demonstrate that it's less important to have precision. But I would argue, as Annmarie has referenced as well, the importance of relationship. The relationship really is the overarching value and the avenue to pursuing a good death and pursuing good connectivity with healthcare needs and the provision of those services. So some of the questions that patients have and the anxieties are, am I going to be heard? Is there going to be sufficient help? Am I not going to be abandoned? It's not just the patient, of course. It's the importance of the family or other informal caregivers. And that includes, am I going to be supported in bereavement after death? As Annmarie has referenced as well, especially COVID times, shines a very bright light on that. So what happens in these conversations, as Paddy has outlined, that are so important to make, and that Annmarie's provided some other insights? Well, when we're in these conversations as patients, there's first of all the validation I'm being asked, my thoughts are being sought. Who I am matters. It's also building self-confidence in that relationship. What I say matters. There's the legitimacy of my views. My needs matter in the provision and design of my care. And of course, it fosters agency, so next time, speaking up matters. And that helps fine-tune my care and goes through this virtuous cycle of reinforcing that sense of self. And of course, these conversations also offer the opportunity to express gratitude. And gratitude is an amazing reciprocal experience for both the patient and the healthcare worker. For the clinicians, I think these conversations also have benefits. It awards courage. I think it reinforces core skills. I can hear you. I can hear my patient and the family caregivers. It reinforces patient-centeredness in designing care. And again, it awards agency to the healthcare worker. I can act to improve this patient's care experience. I can act to improve this family's experience of dying and discussing bereavement, discussing survival, discussing meaning. I also think that these kinds of conversations that build trust also support safety and quality of care. I can recognize poor care is something that the healthcare worker can begin to develop. So what I would say is that these active conversations about sensitive topics build generosity, kindness, compassion, trust, confidence, and also humility. I would also suggest that there's a kind of moral resilience that's built that allows us to withstand some of the experiences that are quite stunning if we anticipate them beforehand, but it gives us the capacity to live through them. This human connection is really exemplified, I think, in palliative care, and that's not typical in all of healthcare. So I want to step back to almost a 30,000-foot level to look at a few contextual aspects of the topic that we're discussing today, dying with cancer, and what that experience is. So the cultural discourse on cancer makes dying like navigating a labyrinth within an obstacle course, maybe with a blindfold on. Palliative care offers a transformative direction for more humane, compassionate, caring, and generous healthcare across all the settings and stages of life. I believe that people do want to seek meaning in life and meaning in death when they're culturally supported and logistically supported. And that takes this active listening and building the patient's relationship within the healthcare system among all the fellow travelers in the patient community and in the broader society. As Annmarie mentioned, these are discussions that need to happen more broadly. Now in Canada, we have legislation that allows medical assistance in death. And I think that public discourse that led to the adoption of the first round of regulations, of law and regulations, has, and we're now in the process of some amendments, that this has done an enormous service for reducing some of the taboos. So first of all, let's situate dying. Well, as everyone said, and we all know, we all do it. We don't like to talk about it. There's so much stigma. So what is life? Well, it's being born. It's living as well as we can until we die, which we all will. And from childhood on, we can think about how we want to live until we die. And we all will. So knowing this and talking about this is nearly taboo for almost everyone in our society. Again, Annmarie has talked about this. So we don't talk about death. We don't like to talk about death with our loved ones either. And we don't, or many of us don't, like to talk about sex. But children are introduced through sexual education far earlier in their lives than their decisions about sexuality. So I think we can normalize conversations about sensitive subjects like dying and death. But it seems we're silent on death. And children certainly have curiosity, but we hush them up. So why can't we treat mortality as a subject for childhood awareness too? So let's situate oncology. Well, oncology is a battle. It might kill me. Or maybe I will die someday and it might be cancer, and that I might be expected to battle it. I'm expected to fight cancer. I might win for a while. For the time being, I might lose my battle. It's not like a heart attack or a stroke that sneaks in and suddenly takes me down. I don't fight heart failure. I don't fight stroke. I recover from my heart attack and from my stroke. We don't say we are recovering from cancer. I fight it until I win or I lose. I'm a survivor or I'm dead. So dying with cancer is popularly viewed as losing to cancer. Why would I want, or anyone want to accept being a loser? So it's a short distance to saying, well, palliative care is for losers. And there is this stigma that we all are familiar with around the word palliative care, the concept of palliative care, the fear of it. That's labeling me as a loser. Hospice is for dying. It's not for living well as possible until reaching a good death or building a good death. So all of this rejection of the organic cycle of life and death create a really hazardous environment for these really supportive and productive decisions and discussions about planning a life that's well lived right through a meaningful death. So let's situate cancer. The 20th century has, and the magic, the miracle of antibiotics and vaccines has increased life expectancy. So death from cancer is more likely. And we live long enough to have the privilege of dying of cancer. So this life extending experience that we have also means that it's very likely that we're accommodating multiple degenerative conditions when we get that diagnosis for cancer. It's not so simple. So as the older population, as demographic grows with more complex healthcare needs, there's also an increase in the technology and quality of diagnostic ability with cancer. A patient is more likely to be a person with other age-related comorbidities, which may give them some advantages as being an experienced patient. They may already have some of the skills in being able to express their agency as a patient. Or it may mean that the cancer diagnosis is an overwhelming burden on an already precarious self-managing situation. So because of the campaigns on screening and advances in diagnostic technology, I think we also can see that people of every age discover their cancer more easily today. And of course, this is complicated by issues of overtesting, overdiagnosis, and overtreatment of cancer that in fact would not shorten life. Whereas the treatment, as Annmarie referenced, may very well change the quality of life. So there's more cancer. But what about the culture? Well, we have screening campaigns that tend to be driven by fear and guilt. Patients and families' knowledge of cancer may be very outdated, that it's about grandma's cancer. That's the culture within a family. So stigma can resist that welcoming of palliative care as integrated throughout all cancer treatment right from the start. I like the idea of rebranding an expanded and an embedded palliative care. So that becomes the definition of what is kind and caring care throughout the whole episode of healthcare encounters in adult life. I think it's a great idea that's really needed for all complex and chronic conditions. So maybe all of healthcare. This helps us reorder priorities around what's popularly referred to as what matters to the patient. But I think that there's more. There's a third theme I'd like to touch on, and that's to situate family. Many more people today are living alone, not only as a nuclear family, but also everyone seems to be having fewer kids, or maybe no children at all. So the extended family size is smaller and more scattered geographically. Certainly, there are plenty of baby boomers who have lived through the sandwich generation, looking after kids still living at home and elderly parents in their declining years who require more help. They say, many of my friends say, I don't want to impose this on my own kids the way I've experienced it. So I don't want my children to be having to be my caregivers as I become more needy. Also, many of us took zero population growth from the 1960s and 70s seriously, and we don't have kids. And this conflicts with the system expectation in its model of care that family is there as the built-in caregiver. So medical practice focuses on the individual patient, defining illness as an individual experience, that diagnosis and treatment is for the individual. But by contrast, the model of care assumes that it's family support that provides the practical support for being cared for. That's the transportation, the safe housing, the food supply, the communication system. Also for caregiving, the family is to be the caregiver, and that's medication management, personal care assistance, status monitoring, being aware of when a patient is doing poorly, decision-making support. And then finally, the family is expected to provide care navigation support. That's coordinating all the medical services. It's information transmittal. It's data quality assurance to error-proof medical records and record keeping, and to connect up information between our often fragmented care systems. It's also problem solving. So without these personal helpers, the path to diagnosis may be slower and bumpier. The standardized care planning may be mismatched or really burdensome. And more importantly, the healthcare provider is focused on the person with the symptoms, making assumptions and perhaps disregarding the participation and influence or the absence of a person's non-professional circle of care. If the patient hasn't gotten relationships with people to help them interacting with the health system and joining up their care, then the risk of harm from care failures becomes truly significant. So maybe in the therapeutic environment that the paradigm is all wrong. I've been thinking really seriously about the irreducible unit in healthcare. The therapeutic relationship is family, the domestic unit. Our language isn't very good about describing this, but the person and their immediate companions in life and death upon whom they rely and for whom they have responsibility. So I was delighted to learn in preparing for today's talk about the WHO recommendation that we approach persons with non-communicable chronic disease and their caregivers as a unit of care, focusing on the well-being of the patient-caregiver dyad rather than just on the patient. And I think that this is a brilliant idea. It's embedded in an article that I was reading about in palliative care. So it's not only better for the person with cancer, but it is the source of meaning in living to death. So we situate meaning in the relationships across our relations, across proximity and commonality, across generations, and across experiential gulfs. Those relationships are also the basis for much ritual about meaning in death. Loneliness erodes the possibility of meaning in dying. So instead, I think that focusing on building relationships, not only throughout life, but also as the end of life approaches, fortifies the possibility for intergenerational wisdom and insight, and also that healthcare does not end when one person dies, that care continues for the entire network. This helps build meaning through the succession rituals for survivors. That is both on the patient side, but also the resilience and the capacity and the compassion for health professionals, because they experience bereavement as well. So I'd just like to wind up by thinking about how the circle of survivors can be supported by sharing wisdom with the dying and sharing wisdom with the living. And isn't this what generations before us did when they lived in each other's lives in multiple large generations? This transformation has so much to offer healthcare. And so the bottom line for me is, and I've been thinking about this for a long time, that palliative care models true patient-centered care. And it's time now for palliative care principles to spread across medicine. It's time to recognize the emerging ways of thinking about this irreducible unit of care everywhere, to be the person and their immediate circle. There are implications for training and for the curriculum in for health professionals, also for building relationships to situate care within the multiple facets of community rather than isolating the sick and dying. Thanks very much, and I really look forward to your questions.
Thank you so much, Carolyn. That was an excellent and a really thought-provoking presentation, and thank you for the focus on communication, talking about death and dying, and the model of care in relation to family and changing family dynamics. I would like to move forward swiftly then into the questions, if we could, just to get a maximum time in those. So I'd just like to ask our speakers, first of all, to unmute themselves, and I'm going to then go through some of the questions, and our speakers then can answer them. So the first one is, how do you feel about being honest about people and how they die? At Compassion in Dying, we often get calls asking about what the last few days will be like, and I worry that people sugarcoat this too much. A peaceful last breath doesn't always happen. Annmarie, yes, thank you.
Yeah, so I completely agree. This is something we've seen a lot in national surveys that we've undertaken. And there's an upshot to that, because if people don't understand what is part of the natural dying process, no matter what it is, then that's when patients end up in an ambulance or going to A&E. So it's really important. I don't think we're honest enough. There are resources, as I said in my talk, unfortunately, they're just not hitting the right spots. And there's excellent resources from Marie Curie, for example, and that's just one example. So I completely agree.
Yeah, I'm not entirely sure about how much it's sugar-coated. In my experience, in popular culture, TV shows, dramas, and news stories, it often seems to me that nobody dies peacefully. And while I accept the spirit of the question being that the converse of that, my experience is actually often the other way around. And I think it's very reasonable to explain to most patients that most of the time dying is not a traumatic, painful, dramatic business.
I guess, I mean, I agree, Paddy, you know, it's most of the time. It's a bit like the side effects for radiotherapy and chemotherapy. They're okay most of the time. But I do think we do need to talk about, and some of the time, this might happen.
Yeah, that's accepted.
Okay, thank you. And just to move on to our next question then, and the focus of this question is, how closely can the process of dying be monitored, particularly within the last few weeks? And how can it become more of a partnership between patient care and clinician? I think that that's a really important question.
Yeah, I'm not sure in what sense the monitoring, what sort of monitoring we're talking about here. Are we talking about being a? I'm not quite clear what the question's driving at there, actually.
So I think it's really around the process of dying. So initially there was a prognosis, approximately 6 months to live. In fact, she lived 7 months, but in the last few days, we were not clear exactly when she was going to die. So that process of dying wasn't monitored very closely within the final 2 weeks. Okay.
Well, I think one thing I didn't cover in my talk, but which is absolutely key in prognosis and prognostication, is prognostic communication. And it seems to me that really, particularly as death approaches, the key, if you like, the monitoring is the feedback. It's the regular contact with family in particular, because regrettably often by that stage the patient themselves is often unable to engage in those conversations. So it's most often conversations with family members around a bedside, preparing them for the expected death. So in that sense of monitoring, of attentiveness and communication with families, I think that is absolutely key.
I think Paddy's exactly right in that this is, in some ways, that this expression is that fear of being abandoned. It is unknown, and the need to feel as though you are companioned through this process, that the family is companioned, that they're not left on their own.
Yeah.
I think it depends as well on place of death and the resources available for that place of death. And certainly someone dying at home may have a very different experience, good, bad, whichever way, than someone dying in a district general hospital, for example. And, you know, I think that dying can be messy. I mean, it's been called the unbounded body. You know, it can be messy, it can be leaky. And so, you know, that can be really scary if someone's managing that at home and the district nurse is 2 hours away, or the palliative care nurse is 2 hours away. So I think the more we know, the better equipped we are to be able to assess the situations and when we actually do need urgent help or not.
And I think the next question that we have probably feeds into this. Why is there a gap between what patients want and what really happens? And what are the barriers, or what stops those very honest conversations?
I think that everyone's honest. Nobody is doing anything wrong in this. It's just there's such gaps in communication, so many missed opportunities. And this is not all, you know, the onus of this shouldn't all be on the clinical teams. You know, the patients and the families also should be taking responsibility for their healthcare and, you know, the way that they live and die. So we found in the PACT study that very often the patients were going to the different healthcare settings, seeing the different consultants and not really understanding why they were there, what decision they had to make in this place, what questions they should be asking. And so, you know, unless you equip yourself to deal with healthcare, then it's going to be very one-sided. And as I said, clinicians are some of them are so scared of disrupting hope, you know, rightly, because as one of the comments in the question box says, some patients do use it as a coping mechanism. You have to be gently, but, you know, it's a dialogue, it's a dynamic interaction, or it should be. And, you know, so it's no one's fault, but we do all need to be talking more about everything, so, to help things along.
I wonder too about the availability of resources at the time, the availability of the time of healthcare professionals for patients and their family members. I've thought about, and I don't know, and perhaps Paddy or Annmarie can fill this in, that there's an enormous service provided by other people who have walked down this path ahead of them. So the support of peers, people who have lived with cancer, who have lived through death with cancer, that expertise is a very rewarding way of making the dying experience have meaning for the bereaved. And it may provide real, genuine expertise for families that are experiencing this at the first time, for patients who are facing their own death, obviously, for the first time.
Yeah, and I can hear my colleague, Dr. Morello Longo, saying yes, because this is something that we have talked about. You know, if you're looking at an intervention to support patients to ask those questions, know where they are, and, you know, decide what they want, then the best person, as you say, to help them is someone that's done it and experienced it all and has a sense of it, together with their clinicians' advice, obviously. And nurses are brilliant for supporting these difficult conversations.
And Annmarie, or sorry, Carolyn, one of the things that you talked about there was time, but one of the other issues is about the skill set of clinicians to be able to have these conversations, and that has also come up in the chat. How can professionals be supported if they feel ill-equipped to have end-of-life discussions, on what additional training is available to them?
I would love for the undergraduate medical programs of all of our training and the nursing programs to embed palliative care as the model, as I said, for all of healthcare, to have valuable skill building for conversations, for active listening, to be able to understand that experience of mortality as the essence of what it is to be a health professional looking after best quality of life for one's patients. I think that palliative care brings us a suite of skills that are essential at all points in caring for people's lives. So I do think that there's lots of work to be done within the professions. Absolutely.
And there is now communication skills is key to medical undergraduate education. I mean, that it's definitely a sea change in the last 20, 30 years in terms of communication skills. But I think there are some specific skills around prognosis, prognostic discussions, and about end of life discussions that aren't generally covered in your classic Breaking Bad news training for undergraduates. And I think perhaps there is a role for developing more either undergraduate or postgraduate training to develop skills in those areas. And perhaps there is a little lack there at the moment.
I think that COVID has really brought this to the fore, because I know locally, and I'm sure there's lots of other people are facing the same thing, the local palliative care teams have really had to support the less experienced clinicians in delivering care of, in these emergency and death and dying situations. What we observed in the PACT study, where we actually looked at consultations and how these consultations were delivered, was it seems that there's very much, it's about experience, that you just get better. The more you do, the more you see, you get better. And I'm sure there are key phrases that can be taught in communication skills, which are, really good anchors to conversation. But generally, looking at the consultations that we saw, it's probably advisable to just watch as many as you can. Watch, follow your senior colleagues and observe what they do, because they've learned over time.
I think there's also a missing piece, which is the value of meaning in professional life, of finding meaning through these relationships, and the intensity of relationships around death and dying can provide a kind of reward for knowing when you're truly helping patients. It's so graphic, it's so obvious that the intervention by the health worker to the quality of the experience of family and patient it can be vivid, and finding meaning through developing these fine communication skills and that experience of knowing how to support and being able to see the value of providing that. So it's, the benefit is two-way. It's not just a benefit for the dying and the bereaved, it's also a benefit for the professional health worker.
Great. Thank you. And just to move on then to the next question, I'm just going to read this out. In advanced lung cancer, even in terminal but treatable with new therapies, it's impossible to assess who will respond positively, but clearly with the prognosis, the patients and relatives can access additional financial and other support, whether benefits or pensions, blue badge, etc. That may make time more bearable. Some patients are now living several years despite clinicians having told them that they only had months to live. The anxiety and the mental fallout in both directions, where clinicians were more optimistic than reality, or the patient overcame their odds. They impact many people, especially in the era of social media where people share their stories online. And how can a balance be struck between the hope and the realism elements by clinicians in terms of empathy?
Yeah, I mean, these are difficult issues, particularly the hope and realism thing. And I think there are two ways of tackling that. One is just taking it at face value, and just talking about hope in terms of survival. We can address that in one way, which is, to understand that when you talk about what happens to 100 people, it's just giving an average is no use. You need to give the distribution of the outcomes and acknowledge the fact that there are people who will do significantly worse and there are people who will do significantly better. So there is always room for hope, because you don't know where on the spectrum of the 100 patients with similar condition you individually are going to lie. But I think actually what I was referring to in my slide wasn't so much hope about survival. It was hope about other aspects of care. It was about understanding that there could still be hope even in the presence of a terminal illness, about still fulfilling life objectives, or still obtaining, dealing with unfinished business and things like that can still be sources of hope, regardless of. So I think you take hope in two ways, and if you think of it in those terms, actually both of them can be addressed and still deliver the news about the prognosis.
Annmarie and Carolyn, I'm conscious that this is our last question, just to give you an opportunity if there's anything you'd like to add.
So hope is, it's just what Paddy said, really. It's about reframing it, but, being honest all the time. So yes, you might be one of the lucky patients, but you might not be. Like, everything just needs to be counterbalanced a bit more obviously and a bit more strongly to, because if you haven't got the truth, if you don't know where you're going and you don't know how bad the side effects are going to be or could be going, then how can you make decisions? It's impossible. So a balance is what is needed.
And I think it is embracing the uncertainty of life, that none of us know in any way what tomorrow brings. That it is about the quality of life. It is about finding meaning in our life. And when we know death is coming sooner for us, or we anticipate that death is coming sooner, building those rewarding experiences, as Paddy has described, finding meaning in the life at the end of life.
Thank you very much. So it is now time to draw things to a close. Thank you all very much for your company and for your questions, which have really contributed to a very lively and interactive session. I'd like to also thank our speakers who have provided excellent talks in relation to dying from cancer, and also the NCRI events team for their IT support today. I think I'd have been lost without it. Please do remember to complete the survey. The link is in the Q&A bar on your right-hand side of your screen. And please also remember to look at the NCRI website for the full virtual series programme. And I very much look forward to seeing you again at a later date.